This chapter is going to cover various allergies and end up with asthma, a very common disease in children and a very common question on the exam. Allergies are usually established by the age of 6 in children. They can be allergic rhinitis, that is usually established by the age of 6. It can be perennial or seasonal. Seasonal allergy is kind of easy to diagnose because you're going to be reading the test question and you're going to see that this patient is going to have symptoms when the lilacs are in bloom, or during the spring, or during the fall. They're going to give you a specific time of year. You're going to look for repeated episodes of this, or seasonal episodes, and that tells you it's seasonal allergy. Perennial allergy is a little harder, but that pretty much means that they're having these signs and symptoms all year round. The more exposure they have, the more symptoms they're going to have. You're going to be looking, you can do certain tests to make the diagnosis, but you're going to be looking at the typical symptoms and at the same time the absence of upper respiratory infection signs and symptoms. So sometimes they can both have a cold, and allergies can pretty much look alike, except allergies don't give you fevers, for example. The allergies will be related to some kind of exposure. So look for that when you're reading the test question. Look for some sort of exposure. Symptoms include a runny nose or a scratchy nose, sometimes a scratchy throat or palate, and the child may be clearing his throat all the time, or going like that to kind of scratch his throat. They can have a postnasal drip, which is worse at night, and that drip down the back of the throat can stimulate coughing. Mouth breathing and snoring are all signs of allergies. They can also have watery, itchy eyes and some drainage. Usually it's clear. And typically they can have even progress to wheezing. Typical behaviors of a child with allergy includes the allergic salute, and I'll show you a picture in a second. They can also really rub their eyes real hard and grind there with their thumb and the side of the fist because of the itchy, watery eyes. This is what we call the allergic salute. The child has a runny nose, and so he kind of sniffles and rubs at his nose. It's called the allergic salute. Sometimes you'll see what's known as a nasal crease. So if you salute a lot, that nose is being pushed up, and you develop that crease in that area that is actually visible when the child is not rubbing his nose. You can also see what are known as allergic shiners. This is all secondary to venous stasis. They have congestion in the nose, they have venous stasis, and so you see these allergic shiners under the eyes. We'll also show you a picture of Denny's lines. These are just typical signs and symptoms of allergic rhinitis. They can have a conjunctivitis. Certainly allergies are one of the factors responsible for conjunctivitis. The transverse nasal crease that I just mentioned. When you look in the nose, you will notice what are known as swollen, boggy, pale, edematous turbinates, and a postnasal drip. Patients with allergies are at higher risk for otitis media with effusion because the congestion can change pressures in the eustachian tube and lead to ear infections. Right here, kind of dark eyes. This is not a Kaplan student that's been pulling an all-nighter. This is the allergic shiners. You can see that they're a little darker. This is from venous stasis. Okay, little bit of a fold or crease there, Denny's lines, also known as Morgan's folds. Your differential diagnosis includes, for example, your upper respiratory infection, inflammatory rhinitis, nasal polyps. Remember, if they mention the word nasal polyps, start thinking of cystic fibrosis right away. A deviated septum can cause nasal congestion and breathing problems and mouth breathing and snoring, just like allergies do. Overuse of topical vasoconstrictors. Patients that use nasal decongestants, these vasoconstrictors, when they wear off, you get a rebound edema, which causes more runny nose and more nasal congestion, and so they're obligated to use them more and more, and that can mimic an allergic rhinitis. And then the less common are going to be neoplasms like a rhabdomyosarcoma in the nose, or a vasculitides, or any granulomatous disease. There's not a lot of laboratory evaluations, but if they press you on one, or if they give you any information, as they do many times, they might give you lab values in the stem of the question. Look for eosinophils. You can see eosinophils in the nasal wash, and you can see eosinophilia in the blood. And the nasal wash is probably a little bit more reliable. So look for the term eosinophils. There's a lot of things that can cause eosinophilia, and we can use the mnemonic here. We use the mnemonic NAACP. So N stands for neoplasm, A stands for asthma or allergies. The second A stands for Addison's disease. The C stands for connective tissue diseases, and the P stands for parasites. That's a nice, simple, quick differential diagnosis of eosinophilia. You can get fancy and get serum IgE, but probably the best test you do, or the first test, is going to be eosinophilia in the nasal secretions, and it's pretty much a clinical historical diagnosis. You can do the radioallergosorbent testing, the RAS testing, and you can do skin testing. The management of allergic rhinitis, if at all possible, avoid what's causing the symptoms. It's kind of hard to do that if it's a seasonal problem, or even sometimes perennially if it's something that's out there in the plants, like ragweed or pollen or things like that. Unless you move, you're not going to be able to get away from it. So the next best step after avoidance is to use various medications. And the first line of defense is going to be antihistamines. Corticosteroids that are inhaled intranasally are also very helpful and get you off those decongestants that you would use intranasally. Cromolyn is a mast cell stabilizer. And remember that cromolyn does not work well in the acute phase. So it works best if you know when your season is. Like, for example, if you get hay fever or allergic rhinitis in the fall, well, you need to start taking it like a month before your season starts so that the mast cells are stabilized, but it will not help in the acute phase. Decongestants, you do need to remember that topical decongestants, you can develop a kind of dependence on them, so you have to be careful with not using them very long. And you need to treat secondary superinfections with antibiotics. Major complications of allergic rhinitis. These patients have underlying allergies. They can go on and grow up and progress to have asthma. We'll talk about asthma a little bit later. And as I mentioned earlier, they can have eustachian tube dysfunction from the congestion, and that can lead to effusion or secondary otitis media. The enlargement of the tonsils and the adenoids, which are tissues that are used that are very important in immune mechanisms, can get inflamed and enlarged. That's what can lead to the snoring and the snorting, and actually can cause obstruction. So sometimes, as a complication, they can get infected, and sometimes they actually need to come out. You can also have emotional and psychological and learning problems. If you're not sleeping well at night, you may not be paying attention in school. It's also very hard to pay attention when you're sniffling all the time and sneezing. Allergic conjunctivitis is a cause of ocular allergy. Again, allergic conjunctivitis can be seasonal, so look for a history in the stem of the question of whenever the pollen is out, or look for a history of exposure, and that will help you with allergic conjunctivitis. Usually it's the tarsal and or the bulbar conjunctiva that are affected, and so they will get vasodilation and they get very red. It's not really a pink eye. It should be a specific diagnosis. We call it conjunctivitis, allergic conjunctivitis. It can be associated with other allergic diseases, and the best treatment is going to be topical antihistamines, and you can also use vasoconstrictors. Allergies to insect venom, probably the most common thing you'll come across, is going to be bee stings and wasp stings, the yellow jacket. One thing about yellow jackets, and they can sting more than once. A regular bee stings once, but the other wasps or whatever can sting more than once. Usually it's a localized reaction. You can get some burning and swelling and erythema there, and it hurts. It can also itch locally, or you can have systemic pruritus. Systemic reactions will include pruritus. If you're really sensitized to them, you can actually have airway problems with wheezing, and you can have anaphylaxis, toxic symptoms of anaphylaxis. Delayed will be a serum sickness-like illness. They can also progress to nephrotic syndrome and neuritis, and even an encephalitis. Those are rare. Typically, you can have local reactions, and you have to worry about anaphylaxis. The best thing to do is skin testing to the actual venoms. These are done in an allergist's office under controlled circumstances, and you're going to look for what kind of reaction they have. Local reactions are mild, and really you just have to treat by removing the stinger. As they start to have more systemic signs and symptoms, then you up the treatment regimen. With anaphylaxis, these patients should always have an epinephrine pen nearby that they can just jab themselves with it as soon as they get stung before they have any problems. These patients should also probably use antihistamines. And then severe reactions that have positive skin testing, those go on to allergy immunotherapy with desensitization. Food reactions. Earlier we talked about nutrition in children and in infants in particular, and we said that we should introduce one new food at a time. That way you know if the baby A likes it or not, B is going to react to it or not. And you don't want to introduce them too quickly because a reaction may not occur with the first exposure, and therefore you can be confused if you introduce too many foods all at once. The majority of food reactions are listed there with egg, milk, and peanuts, and then other nuts being the main perpetrators. Almost all milk allergies are developed by 1 year of age. We try to avoid cow's milk under 1 year of age, so we're not introducing foreign allergens and proteins to the baby before that time. Most children will outgrow milk and egg allergies and go on later on in life to enjoy milkshakes and cakes and things like that. However, nut and seafood allergies are for life, and they can be quite severe. And food reactions are probably the most common cause of visits to the ER with anaphylaxis. It is an IgE-mediated response. Manifestations on the skin, you can have urticaria and angioedema, which is the most common. These are deeper layers of skin if you're talking about angioedema. You can also have atopic dermatitis. You can have pruritus. Gastrointestinal symptoms include nausea and vomiting. They can sometimes have abdominal pain or even a bloody diarrhea. Respiratory symptoms are usually not that common unless it's an isolated respiratory allergen. And certainly if you have anaphylaxis, you can see hypotension. This is a rash of urticaria. A lot of people call them hives or wheals, and you can see and actually feel the rash. You'll have areas that will be erythematous and raised. So this is nice, a well-circumscribed area. If you press on them, they blanch. They will sometimes coalesce and run into each other and become big splotches. So this is urticaria. You can diagnose food reactions with skin testing and again with RAST tests. And one way is to do food elimination. Take the food away, wait for a while, reintroduce it, and see what happens. You know that that's the food that caused it. That's probably the best test. And the only treatment is to eliminate that particular food. So if it's a nut or peas or whatever, you need to avoid them at all costs. Urticaria and angioedema. This is a spectrum of disease. I already showed you a slide of basically the rash that occurs with urticaria. It can progress to deeper layers, and then we talk about angioedema. Urticaria, also known as hives or wheals. Angioedema is the deeper layers, and when we talk about hereditary angioedema, we talk about other organ systems too. Causes of angioedema and urticaria vary. We've discussed already certain foods can do this, but also certain medications can cause urticaria and rashes, and that people may be labeled allergic to that medication. In children, sometimes it's not the medication itself, but if it's a liquid preparation, it could be some of the additives, the food colorings, the dyes, the flavorings that they put into it, and not the actual antibiotic, for example. And certainly viruses are also a cause of urticarial rashes. Sometimes a patient is on a medication, an antibiotic for a suspected ear infection, and they break out in a rash, and you don't know if it was the antibiotic or maybe they just have a virus and the infection is actually causing the rash itself. As I described earlier with the slide, these are well-circumscribed lesions that can actually run into each other and coalesce. They do blanch. They can actually feel a little bit raised above the skin. Very easy to feel. In angioedema, they then affect the deeper layers, and they can affect the GI tract and the respiratory layers. The treatment of urticaria is going to be antihistamines, and you may need to use epinephrine, but usually antihistamines do the trick. There is one specific entity you need to really remember for the test, and it's hereditary angioedema. It's also known as angioneurotic edema. And this is an autosomal dominant disease. It's a defect in the C1 esterase inhibitor activity, and this is going to cause recurrent non-pitting episodes of edema. Sometimes the deeper layers, it can affect the mouth, the tongue, the airway. I know of 2 patients back home, a mother and a daughter. Since it's autosomal dominant, that's not surprising. They actually have had to have tracheostomies because of these recurrent episodes affecting their airway. So that's hereditary angioedema. This is just the beginning rash of urticaria. You can see it's slightly raised, not as coalescing as the earlier one. And here it looks almost like goose flesh or goose pimples. But then they start to blend together, and they can itch. And once again, like the prior picture, this is urticaria again. They are coalescing and running into each other at this particular point. Atopic dermatitis usually runs in families, and you can again get a family history of this. It is related to allergies and asthma. They will course with eosinophilia. So if they're mentioning eosinophilia in the exam, you should immediately start thinking about allergic type diseases and responses. There's infantile atopic dermatitis. Most of these will be diagnosed by about a year of age. Certainly by 5 years of age, most people with atopic dermatitis, or eczema is another term that they use, will be diagnosed. These patients itch. They itch a lot, and what do they do when they itch? They scratch, and when they scratch, they can get secondary infections. Also, persistent scratching can lead to what we call lichenification, which is the skin in that area gets very, very thick and almost scarred. They can have many exacerbating factors for this. We try to tell them to avoid rough textured clothing because, for example, wool, since it's rough textured, will irritate the skin and make it worse, and they scratch more. It can be a chronic relapsing disease. This is a child with infantile atopic dermatitis, and you can see that a lot of it is on the face. The older onset disease does not affect the face as much. This is characteristic for these lesions that you see on the forehead, also on the cheeks. They are, we call them weeping type lesions. It's almost like a serous discharge there, and they can have crusting in those areas. A lot of times in infants, it's related to the introduction of a new food or introducing foods too early, and you can get this kind of response. Here's an older person, again, with atopic dermatitis, and you can see where they've actually been scratching themselves here. And look at these linear marks where they scratch themselves quite a bit, and they have them here, and even up on the chest, you can see areas of atopic dermatitis. Very dry skin. Here's a baby, again with the infantile form, and you can see it right there, delineated in this pale area on the cheeks. In infancy, it's a much more acute presentation. You can see it on the face and the scalp and on extensor surfaces. So you'll see it like on the knees and on the elbows. As they get older, it'll be a more long-standing disease, and then you'll see it in flexural areas like in the antecubital region. It'd be much more common to see those areas of weeping and exudate and the scabbing and scaling. Okay? And again, if you have a lot of scratching, that skin gets thicker and thicker, and you get lichenification. The treatment is to eliminate anything that's causative or exacerbating it. So you want to avoid rough textured clothing. This is a great one for the kids. You encourage them not to bathe so often. They'll comply with that. They don't want to take a bath all the time. What's happening is when you're bathing, if you bathe them too often, you're washing away their own natural oils, and so the skin dries out even more. You can try using moisturizers. You treat secondary infections and try to avoid Staph aureus infections.